Hello, my fellow stroke warrior friends and families. Today, we're welcoming a real powerhouse from Neuro Rehab, Dr. Jennifaye Brown. I said that right?
You sure did.
Well, welcome. Glad to have you.
Thank you.
You're an educator, therapist, author, and advocate who's changing the way we walk through recovery, literally. I
Yes.
like that. What
Yes.
inspired you to specialize in neurological physical therapy, particularly with stroke survivors?
Well, I had abnormally large and narrow feet, and it was hard for me to find shoes beginning at a young age. And so I always knew I was going into healthcare. My mom was a nurse, but I went to Emory, and the core sciences were weed out, and I always thought I was going to be a pediatric surgeon, and then I just decided maybe this is not for me, and I went to the Allied Health Fair, and it had physical therapy there spring of 1985, and I started volunteering at the hospital, and I had this penchant for looking at how people walk, particularly their feet. And I never got out of that. And so I knew I wanted to go into neuro because I did really good in anatomy and neuroanatomy. And I was really good at linking where you have a problem in the brain and what your body should look like. And then health became really important for me. Well, everybody can't afford rehab, but there are two things they can't afford. They can afford to walk and they can afford to exercise. And so, since going back to me now with these large, narrow feet, and in order to walk more efficiently and safely, you needed a foot brace known as an AFO. I decided that I'm going to be the person to make them, particularly for women, so that they could fit in the shoes that they love, so they wouldn't have to wear a sneaker for the rest of their life. And I was really thrown into it before I was ready, but that's because I did a good job at rehabbing people for walking. And so one person told me, she was a socialite, and she says, I don't own sneakers. I don't do Alta. I go to Alta. She doesn't play tennis. She goes to see the other people play tennis. And I do remember to this day sitting with her in Neiman Marcus to find a pair of shoes that would fit her ankle foot orthoses. So I really started gearing my specialty of making AFOs after I became really proficient at teaching people how to walk.
Great story.
Yeah.
You've been board certified 4 times over 40 years. What have been the biggest changes in stroke rehab since you've started?
I think the biggest change is how we do exercise for the long term. And we've got all of these clinical practice guidelines. But my issue with the clinical practice guidelines is that they don't take in the social determinants of health. What makes a person a person? Who they interact with, where they live, their health literacy, their health status, their environment. And so I'm not so quick to go to the CPG, the clinical practice guideline, and do what it says. I'm more apt to ask the person, who are you? What is it that you want to do? Did you exercise in the past? And how can I make you exercise for a healthier lifespan as opposed to just rehab? I think we're finally getting it that physical therapists are movement scientists. We can analyze movement. So we need to teach people to move for the long term, just not for rehab. And I think that's the biggest change.
Yeah, it's more of a holistic approach for some of the better ones. And
Yes,
and a lot of people don't realize there's a big difference between a neurophysical therapist and a physical therapist.
correct.
You know, I mean,
And
Go ahead.
I would add what makes me different as a neurophysical therapist is I know the neuroanatomy, the neurophysiology, and the long-term impact of where a lesion is in the brain and the spinal cord and how it will change the output or the sensory input from the body. I think
Yeah,
that's the key difference.
yeah, exactly. It's funny too that you were saying how you talk to your patients. My second therapist did that for me, and it was great. She asked me what I wanted to do, and I was a contractor before. I said, I
Mhm.
can't climb a ladder anymore. She brought a ladder into physical therapy.
Yes.
That's the kind of physical therapist you want, not the ones that
Yes.
check off the little protocols.
Correct. I had a ladder in my outpatient physical therapy place where I worked. I also had a skateboard. I had a fishing rod. Some other
Friend of mine had
unusual,
to learn golf again.
yes, golfing and hockey. We had a
Yep.
hockey puck and stick. So yes, and I tell people that's important because these behaviors that they do are deep rooted in their system, and they can't, you just can't erase this unless the stroke was in your memory center for long-term memory. But you just, so if their body already knows that movement, let's go back to what they know and then build upon it and modify it so that they can continue to do it again. It may not look perfect like it was before, but we can get them back to doing that and problem solving through it in the context of their environment based on what their body is looking like and the abilities, not disabilities, but the abilities of their body.
Totally. It took me a long time to learn all of that. I
Yeah.
mean, they don't tell us what it's like going to be like, number one,
Mhm.
and secondly, you get the ones that check off the protocol. So I think most um, stroke survivors or stroke warriors, we say, um, need to learn how to select a physical therapist. Don't you agree?
I agree. And so in my book, I provide a chapter for individuals with stroke about what to ask their physical therapist as it pertains to their foot brace. I've empowered them with the questions. And I tell them, if they don't like the questions you asking, tell them Dr. Brown said to ask you this. And there's another chapter for them to ask the orthotist questions also.
Wonderful. Wonderful. What does the phrase functional independence mean to you?
Okay, so functional means is it is it something relatable and doable for your sustainability in life? All right? Is it relatable and doable so that you can sustain your life? Independence means you can be independent without a person, you can be independent without a device, you can be independent with a person in the room, you can be independent with the use of device. It's how you feel about independence. So I have sickle cell disease, I'm prone to stroke, I've had joint replacement, I've had a reconstructed knee. I still keep a cane in the car. I still keep a cane in the car. I can be
As do I.
independent with my cane.
Yes, I
I
agree.
don't have I can be independent with my cane. And so we always think of this independence of being just you by yourself and nothing external. Well, sometimes I need to walk over to the rail and hold on as I go step over step at the age of 58 because I still want to be able to do that. But just in case that knee gives out, I'm holding on to the rail, but I'm independent holding on to the rail.
I love that thinking. That's amazing. Um, the You've helped thousands probably, I think, based on 40 years of experience, better understand mobility. Let's talk about one of your favorite tools, the AFO. Because,
Okay.
and in particular, I'm asking this because I didn't get an AFO until I was 6.5 years. Nobody
Okay.
ever told me about it. And 6 months later, I was off my cane.
Yes. So sometimes our foot needs a little help. And the purpose of the AFO is to pull the foot up, but not to block your leg. Your leg is everything below your knee from moving forwards or backwards. And so, what I have done with the AFO is number one, conformed it to the foot of the person. If you go to my book at the end of the chapter, it has a page of AFOs. They all look different. They're not the small, medium, and large that you get from um, off the shelf or from Amazon. And I have gotten those small, medium, and larges, but I was smart enough to heat them up, fine tune them, change the strapping to accommodate the person. And that's another thing. My AFOs are so person centered. The AFO that I make for the mom who had her stroke during childbirth is different than the AFO that I'm going to make for the duck hunter to wear in his boot. So the first thing is I look at the person's shoe that they wear the most. I look at the outer sole and it tells me a lot about their weight bearing patterns. Are they a pronator flat foot? Are they a supinator? And they wear out the lateral part of their shoe. And then I take the inside lining out of the shoe. And I tell the orthotist, I want the bottom of the AFO to look like this because this is their normal foot. Now they have some other issues because of the stroke. Their foot may be floppy or tight. The muscles may be weak, but this is still the normal weight bearing pattern of the foot. And so I use these two key pieces of information for the best outcome of the AFO. The next thing I've changed on the AFO is I use tension straps as opposed to the rigid Velcro strap that goes through the metal loop and comes back across the front. Before you walk, you have to stand up. When you stand up, your knee comes forward. While you're walking, your knee comes forward. Well, if I limit the knee from coming forward, I prevent the foot from getting strong, I prevent the calf muscles from getting strong, and I preclude the muscles of the thigh and the butt from getting stronger. They remain in a state of weakness. So, based on how strong you are, everybody gets a different tension strap. And so earlier, these tension straps were different colors. And if you look at some of my AFOs that I've made, and they all have stretchability. So this one says 55% stretch. And then this is a MedFlex, and I had to cut off the tension on that, but see how stretchy that is. So the weaker you are, you get something a little bit more durable. So the first thing I did was, depending on where the lesion was for the stroke, I wanted the force to go forward from sit to stand. And in order to do that, I had to give them a tension strap. So, how I treat and make the AFO is different based on where the stroke lesion is. Those are some key differences that I do with my ankle foot orthosis. There are some other things I do with exercise, but that should get the conversation started.
Do AFOs necessarily, at least in the beginning, have to be custom or should be custom, I should say, because a lot of people can't afford it. I mean, is an AFO worth it pretty much anytime?
It depends on the lesion location and how weak the foot is, how much tone, what we call tone, is in the muscles, and it can be floppy or high tone. A floppy foot may have a really movable ankle, so I need some stability in the ankle. A high tone foot may be pointed down. I may be able to get the foot to be level, but I got to do some different type of work, and I got to make sure that heel cord stays stretched out. But if you're a lady and you wear a 1 inch heel shoe all the time in the rear, maybe your foot pointing down is not that bad. I just tell you to wear your shoe with the heel, and we can disguise the AFO through your shoe. But a lot of people don't look at that. So Early on in acute care in the hospital, day 3 after the stroke, I'm using TheraBand, I'm using ACE bandage. But we all know that once you've had your stroke on day 1, it takes 6 to 8 weeks for everything in your brain to heal, edema to leave. It's called this cascading event. So I never get the permanent final AFO early into rehab. And I had to stop doing it anyway because the insurance company wouldn't pay during the inpatient rehab stay, which we call acute rehab. And
Right.
here's the thing, a lot of people are showing up at the hospital sicker and they need a longer um, inpatient rehab stay, and sometimes they have to go to subacute, and subacute is at a nursing home. So you get up to 80 days paid for, then you have to start paying, out of pocket that 81st day. So sometimes there, it may be a good time to get the AFO because now you have to work at a lower intensity level for a longer time, and you can
Well,
get your final AFO further down the line. But I was well trained, Beverly Cusick, and I remember going to a lot of courses that had orthotists in them. So we worked as a team. I could probably whip you up an ankle foot orthosis for training purposes in under an hour. I started using like plaster of Paris way back in the day. Now I use it's like a casting material that's it gets hardened once you put it in water. And I've made a lot of those in the homes, and the people have taken that AFO to the orthotist, and it's the prototype. And I've had people say, well, the AFO that the orthotist made isn't as comfortable as yours, so I don't wear that one. Can you come back and make me the one that you made? And that's because I do all of these nuanced things that the orthotist may not do because they don't know the person's walking speed. They don't know the changes in tone from laying down to sitting up to standing up. They don't know the eccentric strength of the muscle versus the concentric strength of the muscle. That's why some of my AFOs have a thicker wall on the outside and a thinner wall on the inside of the foot. So, like, see how this moves?
oh, yeah,
Everybody doesn't need that, but this is rigid. This won't move on this side.
that would have helped me a great deal. Your book, you've written a book called Brace Yourself, which breaks down everything about AFOs in a couple chapters. What misconceptions or fears do survivors and caregivers often have about AFOs?
They think that you have to wear it and the strap at the top of the leg has to be tight and you can't loosen it. Well, if you don't loosen it, the muscle won't get strong. If you keep the straps down at the ankle, the muscle that pulls your foot up, it will be cut off from the pressure of the strap. My straps usually start on the lateral side, the outside of the ankle, and goes to the inside down by the big toe. Why? Because when you walk and your knee comes forward, your leg bone turns. And so in order for it to turn, your foot has to flatten out. Keeping a strap across the ankle doesn't help the foot flatten out. But if you have a strap from the lateral side going to the inside, the outside of the foot to the inside of the foot by the big toe, the foot flattens out. Your leg can move forward and you get better walking. So the misconception is that you have to wear it and you have to keep that strap fiercely tight all the time. Doesn't work. Actually, sometimes it can lead to falls because when you fall, you want your center of mass lower to your base of support, and then you want to stop. Well, when you wear an AFO that tight with the strap across the top like this, your knee can't come forward. You want to be able to squat. And so I tell my clients that during the therapy session, we're going to wear the AFO and then we're going to loosen the strap just enough to put my fingers in between. And then you're going to practice scooting forwards and backwards in your chair and side to side. And then I'm going to put a rolling pin under your foot and you're going to roll your foot on top of the rolling pin so your knee can come forward. And when I'm doing all those things, I'm strengthening the muscles in the front of the calf, the back of the calf, and the outside of the calf. But that won't happen if it stays fixed. And I've had a lot of people, oh, we heard you're a great therapist. We need you to come. And I said, okay, well, we're gonna loosen something. Oh no, we can't loosen the strap. I was told it has to stay on because my leg is weak. And I said, well, if you want your leg to get strong, and it has to get strong three ways: isometric, which is the muscle stays still; concentric, the muscle shortens; and then three, eccentric, the muscle lengthens. We're gonna have to loosen this strap. And then I just ease them through that. Oh, and
Yeah,
this is, oh, I can feel my muscle working. I said, yeah, it couldn't work with the muscle, the strap all tight like that.
yeah, exactly. It braces it so it doesn't move.
Right. And then I tell all the people who have hip pain and pain in their side flank, the reason why because you're hiking your hip, that's because your knee can't bend. And your knee can't bend because it's in that rigid Velcro strap of the AFO. We need to allow your knee to come forward. Biggest
What,
misnomer.
yeah, what is, in the beginning, I mean, the medical profession and sometimes where we wind up as non-neurophysical therapists, they don't tell us, in my case, didn't tell me about an AFO. What what is a new stroke survivor looking for as far as symptoms that they may need an AFO?
Their foot is dragging on the ground. The top of their shoes is worn off because their foot is dragging. They're having to lean over to the other side to walk because they can't bend at their hip because it's weak. So if you pull your foot up, then you don't have to lean to the other side or hike your hip to clear the foot. And it's okay that your knee doesn't bend. If I could just pull your foot up and let you slide your leg through, I can clear the floor 1 to 2 inches by telling you to rotate your pelvis. So two big things. Your foot is dragging and you're having to hike your hip or lean over to the opposite side to clear your foot, and your toes of your shoes are worn off. It's just worn from being dragged all the time. That's the biggest sign. And then the third thing, because of leaning over to the side and hiking the pelvis or hiking the hip, they have low back pain.
Explains a lot for me.
Yeah.
So that includes the circumvention where your foot goes in a circle
It,
outward.
yes. So it goes out to the side because your hip flexor, the muscle right that crosses your groin, is weak. But sometimes I think it's weak. Sometimes I think it's compensation. Because if you lean your trunk to this side, where does your leg go? It goes out. And then you bring your trunk back, where does the leg go? It goes out in front of you. So you're doing all of this with your trunk when all I had to teach you a day or two after your stroke, look, um, there are two exercises I need you to do. Your hip needs to bend for you to walk really well. So I need you to sit up tall and lean forward and hold that position. And then I want you to sit and take both of your arms and put it under your leg and bring your knee up. Your hip is bent, and then bring your hip and knee down together and then come up. I held the muscle, I shortened the muscle, and I lengthened the muscle in that example. So the muscle got strengthened three ways before you even stood up. And so I'm trying to get that in the muscle memory. So now I can start teaching the walking for that particular muscle. So I think people go out to the side because their leg is stiff, but we didn't teach them how to bend their leg in sitting prior to standing up and how to load it. I can't hear you. I can't hear you.
Can an AFO hurt if it's the wrong design or not customized properly?
Yes, it can. So here I have a lining on this AFO. And so your inside part of your ankle bone that sticks out, if it rubs against it the wrong way, it's not heated right to contour and allow the movement, it can create chafing. And a lot of people stop wearing their AFOs because of that. And so I start measuring the foot in all of its positions when you're laying flat on your back, when you're sitting up, and in standing with your knee in front of your ankle, with your hip in front of your knee. It's called terminal stance. I measure the ankle in those three ways. And then I look at the reduction in flexibility of the ankle. And then we think of an optimal angle for the AFO at the ankle portion. And
Okay.
then I create a trough so that when your leg moves forward, when it comes forward, you're not rubbing against the plastic. That bone has a little trough so that it can move forward and back without hurting. And that's another thing I do with my AFOs that's atypical of other AFOs.
Very nice. You're also a certified aging in place specialist. And I'm curious, real curious about this and how it relates to stroke recovery. But let's talk about home safety and movement friendly spaces.
Well, I
What, yeah, what are some of the most overlooked hazards in stroke survivors' homes?
so the reason why I became a certified aging in place specialist because my clients always came back to outpatient and said, "Oh, I can do all these things at and in rehab, but I can't do them at home. Um, I'm falling at home." And then I said, "What's your flooring like at home?" "Oh, I go from a linoleum with that silver lip, and then I go to high pile carpet, and I'm dragging on the carpet." In our hospital and rehab environments, we want to make everything so sterile. We don't make it like the home environment. So when it was time at one facility for us to get capital equipment, I said I would like a free runner from the carpet store because they're going to just throw them away. And then we're going to tape along the edges and we're going to put a non-skid. We're going to get a low pile. We're going to get outdoor carpet, and we're going to get a high pile carpet, and we're going to do the 10-foot walking test or the 10-meter walking test for gait speed. And we're going to do it on the surfaces that they have at their house because that's more applicable. All right. And so I looked at going to people's houses to make sure that they can walk safely in their houses. And then what was I teaching them in rehab for fall prevention versus fall recovery? And that changed the way we did things in the houses. And so now I'm not asking them not only just how wide your doors are, what is the surface in your home? And if you have a linoleum floor and you're afraid that you're going to slip, can we get one large 5x7 mat for the bathroom as opposed to getting the 3-piece pack? And so my goal was them to walk efficiently and effectively in the home. First thing, if something were to happen to you and there's a fire, where's the meeting place? Oh, out by the mailbox? Oh, then we're doing this instead of doing the 6-minute walk test, we're going to test how fast and how safe you can get from your bedroom out to the front mailbox and wait for the person who's supposed to check on you. So I just changed it. And so for the doors in the house, okay, you have a walker or platform attachment because your arm's like this. Can you turn sideways and get through the door? If you can't, I need a Z bracket to open up the door wider, or we're going to take the door jamb down. And if you want privacy, we're going to put a tension rod with a curtain, and then we're going to put a hook to the side so that you can still go through. Because everybody can't afford a new door frame. So sometimes I just had to take the door off because people want to go into their bathrooms, but they can't fit in there because the width of the door.
Yeah.
So simple things, adding lights. And the light can come on when it detects the motion. Your favorite couch. Oh, I don't want to get rid of the couch. Can I put a wooden slat underneath the cushion and then add door stoppers to that so I can raise the back of the cushion so it's easier for you to stand up? So we modified a lot of things. Well, when I was in rehab, I always got out of this side of the bed. But when I go home, the bed is here. What is it that you really need in the room? Can we get rid of things? So now can we change the room around so that we can get up efficiently and effectively how you learned at rehab? My biggest obstacle, people are afraid to change. This is their house. I don't want to change it. And I said, okay, what can I do so that you can be more independent in the house and stay alone? See, when you reframe the question like that, then things start to change. How much is it that you really need?
How much do you want as
Yes.
well? Yeah, I
But the
mean,
issue, yeah, they want everything. But wanting everything isn't good for your safety for fall prevention.
agreed.
Yes.
Okay, you often recommend interdisciplinary planning. Why should stroke caregivers, PTs, and even contractors collaborate?
Because I can't do everything. And I welcome the opinions of other people who work in their specialty areas. So I know a person wants to get dressed and they only have one arm. I know the mechanics of dressing, but I may not know the nuances of how to get rid of the button and add Velcro so that it's easier to get dressed. Now, on the flip side, I knew the nuances of walking, but people didn't want to wear a brace, but I know how to sew. And so we're going to put a spandex strap from the seam, from the inside seam to the outside seam inside your pants so your knee doesn't snap back when you're walking. So I thought of things that my colleagues didn't think of. So that's why we need to work as a team so the OT can make suggestions for the clothing because I know something about gait.
Yeah, it's amazing to me that they didn't tell us that in my opinion, there's 9 different therapies. I was given 2 therapies to start with. I didn't learn about the other therapies, the mental health in particular.
Yes.
The acupuncture is available, the massage and chiropractic. There's so many things available out there. And one of my favorite sayings is the only dumb question is the one you don't ask. You
Amen.
ask all the questions. That's what makes your book so great.
Yes.
Um, let's talk about aquatic. And again, another thing dear to my heart. I got on a water treadmill at 7 months, 7 years.
Mm-hmm.
And within 6 months, I was doing a 24-minute mile. And within a year, I was doing an 18-minute mile on a water treadmill. Why is water-based therapy so effective for stroke warriors?
You get rid of gravity. You're pounding the pavement literally when you're walking outside and gravity is pulling you down. So you got to lift up against gravity and you got to move forward. Water takes all of that away. So now you can move easily with the buoyancy of water helping you up. But I'm smart enough that I need to make you stronger. So I know what movements to do in the water to make you stronger and not only build muscular endurance, but cardiovascular endurance. And some things are easier to do in water than it is over ground that will help you walk better forwards. The people in my aquatics class now don't understand why we got to walk backwards in the pool. And now I got them running backwards in the pool because I need to work your hip extensor or your butt muscle when you're walking forward so you're not going down all the time. It's the butt muscle that keeps you upright. And when you go backwards, it's a different type of rotation on your pelvis. I need that rotation going forward so that you can take a longer step. So, yes, you're able to do things in the pool that you cannot do over ground because of the effects of gravity. Does buoyancy help you and make things easier? Yes. I do need things to be made easier, but I can also take away the negative effects of gravity in the water. I can train people differently. And there's always the steps, there's also always the shallow end. I can start the land based things and the effects of gravity at the stairs going up and at the shallow end.
Yeah, and I now do a regular treadmill. So I mean, I did a year and a half. I still go occasionally because it does good for my body. So I
Mhm.
mean, it's an amazing therapy. How can survivors safely reintroduce exercise even years after their stroke?
Safely start in bed before you get up. Roll to the right, roll to the left. Just move in bed. Make angels on the mattress instead of angels in the snow. Before you even get up, can you push your butt back in the bed on one side? Push your heel down back on one side. Can you roll over and then grab and hug your knees? So just
Oh,
movement and getting used to doing movement in different positions. Everybody says you got to stand up to do exercise. No, you don't. You can sit down and you can lay down. I have a whole routine that I do with TheraBand in the bed before I get out. And on my bed, I tuck in the sheets and the cover that I'm using. And so when I try to kick my leg up, my leg only goes so many inches. So now I've got resistance of the sheet for kicking my leg up. So I kick my leg up on my back, I kick it up on my side, I lay on the other side, then I lay on my stomach and I kick up against the resistance of the sheet in the spread. And then I
wow.
have TheraBand for my arms. If you have bedposts, I would tie TheraBand on the bedpost, bring them down in an X. Diagonal movement is so much better than straight plane movement. I'm eating. This is eating. My arm is in a diagonal away from my body. I don't eat this way and I don't eat this way. Sagittal
Right.
plane, frontal plane. But why do we teach those exercises? When are we going to do the diagonal plane? So I'm very much into diagonal plane. And so right now I teach an exercise class at a senior center and we're all sitting down. And I just asked for one piece of equipment because there were two muscle groups that we cannot strengthen against resistance sitting. And I changed some positions while sitting in the chair to simulate getting up from the floor and half kneeling. And it's new to people, but I have to go back to function. So any movement is good movement. So you watching The Price is Right, and there's a 90-second commercial. I need to be clapping the whole time. Clap high, clap low, clap to the side, other side, clap high, clap low. Cardiovascular, as fast as you can, 90 seconds commercial. Exercise during the commercial.
Wonderful. You've done a lot of education, empowerment, and advocacy. And you've taught in multiple states. What keeps you passionate about stroke education?
Because I'm at risk for stroke. So I need to be the example for other people. I have sickle cell disease. I am at risk for stroke. And so diet and exercise is what I can do to manage it. And I'm not one of these sickle cell disease patients who's taking pain medicine every day because my pain is reduced because I move. And I'm mostly moving in the pool. Well, maybe 3 times a week, I'm in the pool. And I still walk every day. I just have to walk slower and a little longer because the faster I walk, especially over ground to get that high intensity, I'm pounding the ground a lot, so it's not good on my joints. So I make sure I have good shoes. Good, I wear an expensive pair of orthotics that are custom. And so I engage, I'm passionate because I can't go to your house and tell you to do X, Y, and Z if I'm not doing it. And I can tell them, well, this works because I do it. And, I get, oh, you would never know. You're too young. I said, I'm on the near side of 60, already been to rehab for the hip replacement. Because most of my individuals with stroke, they fall and they either
Yeah.
have an ORIF or they have to get a hip replacement. And then the hip replacement is the problem because they have osteopenia, especially if they're female, because they haven't engaged in weight bearing exercises post stroke. And so I'm the poster child for that. And so one of my PowerPoints, the courage to speak, it says you got to talk that walk. So if I'm gonna teach other people to walk better with an AFO, I got to talk it because I've already walked it.
How can, one of the things that most of us talk about up here anyway is we didn't know what we didn't know. How can survivors become their own advocates in therapy?
Ask questions. And if the people are taken aback because you asked the question, respond with, I want to know so I can improve myself. And I think the people get taken aback because they don't know the answer. Well, then if you don't know the answer, you say I don't know the answer, I can find it for you. Or that gives the individual with stroke the impetus to go find the answer themselves. So always be knowledge seeking, ask questions. And then you know what? I'm not a tech person, but this internet has a whole bunch of information. I don't mind people going to the internet. I need you to know how to confirm or refute the information that you're receiving. Because
Or,
everybody thinks if you just exercise, you're going to get back to normal. Not true. It depends on where your lesion is, how large the lesion is, and the time you were without oxygen. Those are the three key factors. But I still need you to exercise because it's good for your heart health and it's good for your brain health, whether you return back to normal or not. Exercise is good for you. You still need to do it.
for therapists listening out there, what's one thing you wish every PT remembered when treating stroke patients, or TBI for that matter?
What if this was you? What would you want? What
Wow,
if this was you? What would you want?
my God, that's a great statement. I have not heard that one.
Yeah.
That's
What if this was you? What would you want?
wow. Cool one. Couple quick instinctive answers.
Okay.
Best home modifications on a budget.
Z brackets for the door so that the door can open wider.
Okay. One word to describe stroke survivors.
Innovative. Innovative.
I like it. Aquatic or land-based therapy.
Aquatics.
Okay. Does the aquatic lead to land-based therapy as well?
Yes, because okay, so in my class, I have a class Monday and Wednesday. On Mondays, we have a 3-minute education. For every exercise they do in the pool, I tell them how they can do it on land. So yes,
Wonderful.
yes.
The
But
most
it's
re
often easier to do it in the water first than it is on land.
Perfect. The most rewarding moment of your career.
Um, when I had a client who I saw in inpatient rehab and they were sleeping. Basically, they were in a coma and I was working with them. And then it was time for the person to transition to my full-time place where I work, which was the outpatient. And he did not understand why I had him standing up, working on something, and then he had to walk down the hall. And I said, I remembered when you were sleeping and there was a possibility that you would not wake up. And so I am enjoying this moment, seeing you upright with the ability to walk. I think his father was just about to break down and cry.
Finish the sentence. Recovery is
Recovery is living your best life, even though it may not be normal.
Dr. Brown, thank you for working with us today and talking with us, literally and figuratively. Stroke Warrior Radio is an honor to have you as a voice in our movements. Where do they find your book and more about you?
If you want the book, Brace Yourself, Everything You Need to Know About Strokes After an Everything You Need to Know About an AFO After Stroke is on Amazon. If you want the ebook version, you'd have to go to my website, jvbneuropt.com. That's jvbneuropt.com. At my website, you can find my email, my phone number. I return the emails, so feel free to contact me. I'm located in Charleston, South Carolina.
Wonderful. And you're also on socials, right?
Yes, I'm on LinkedIn and I do have a YouTube page, but all of my videos are not up yet because we are getting a disclaimer. I do have some 3 videos up there about stroke because May was Stroke Health Awareness Month. But now we're trying to move on and get all the videos about exercises and things that you should do with your AFO. I just need to put the disclaimers up, and that's what we're working on.
Cool. Thank you so much. Have a great day.
Thank you. Bye bye, everyone.
Please don't leave.
I won't.
Okay. Why can't it? Okay, what's going on here? Stop recording. Stop. I think it stopped.
I still see the recording button on my
There it is.
screen.
Here it is.